Very excited to welcome our speaker this evening. It's Dr. Tina Korownyk. Tina is the director of PEER. She's also a professor at the University of Alberta and a practicing family physician. So Tina has many invited presentations and publications, including multiple clinical practice guidelines. She is a leader in family medicine, evidence-based practices, and shared decision-making. She's also married with 4 children. I think I also heard in the thing there's some stir about a podcast that she has been the guest of. So lots of things going on for Tina. I'm really excited that she could make time to present to us tonight. So at this point, I'm going to hand things over to Tina, and go ahead, Tina.
Okay, thank you. Thank you for the introduction, Carrie, and good afternoon, everyone. It's an honor to be invited to speak to this group. As mentioned, I work with PEER, and I work as a clinical physician. I am not an expert in pain management by any means, but I'm going to spend a bit of time just quickly reviewing some of the work we've done on pain, particularly the pain calculator. So now, and Carrie, will you be switching the slides or there?
You bet, Tina. You say it and I will get on it.
Okay, you're awesome. So just a quick background. So PEER stands for Patients, Experience, Evidence, and Research. So we put the patients first because we think that's the most important, and then experience. Because sometimes when we talk to residents about evidence, they want to override every clinician's experience. And then we think that the experience piece is equally valuable, especially in a topic like chronic pain, where we know there's a lot of areas that don't have great evidence, right? So that experience piece is really important. Evidence and then research. And really the main goal of PEER when we were first created is we just wanted to empower primary care by providing them with best available evidence. And sort of to overcome that idea where we're always sort of being told from sort of the top down, this is what you have to do, and don't ask questions, just do it. And we thought, wouldn't that be great if we could just say, here's the best evidence. Now you take that and move with your patient and figure out what is the best for that patient. So that's mainly our vision. So we aim to sort of produce evidence that matters to patients and providers. And we really value fun. We value minimizing bias. And we really value patient-oriented outcomes. So I'll talk a little bit about that in the next couple of minutes. All right, next slide. Awesome. So one of the things we do a lot of research, and you can just kind of, go right to the final one on this one, Carrie. But we've really tried to make like one-page summaries of everything we do. So when we did a lipid guideline, ultimately we took all that work we had done and made one page, because we know we were kind of joking, for instance, that some guidelines are hundreds of pages long, and for a primary care clinician who has 100 different areas of specialty they need to be familiar with, it's impossible to read all of those. So one of our goals, we love simple. We really believe like simple equals the best. So we try to do that with everything that we look at. All right, next slide. All right, so this is just to give you a bit of background on the calculator. So we developed a pain calculator, but this is the background behind it. So everything in that calculator is based on a systematic review of best available evidence. So in case you're wondering, what's the evidence for this? Where did they get these numbers? We actually had 3 different publications where you had systematic reviews, first looking at the management of osteoarthritis. And you can see most of the things so what's listed here are what we looked at. What's in the calculator doesn't always match because we didn't find evidence for everything, but we did try to find evidence. And I'll kind of tell you the evidence that we were looking for. But we tried to find evidence on all these different outcomes for different pain. And we recognize this is still not exhaustive. There's still other things that could have been done, but that we thought it's a good start. And what we were really trying to do is just hit some of the common things. And one of the things to note is this is really aimed for your very primary care practitioner who is just sort of starting out, what are some of the things when a patient comes in with, pain, what's the evidence for some of these things that we've had. And historically, we haven't really been taught that in school, which you guys, I'm sure, know way more than I do. It hasn't really been something that's come up. And so really trying to provide evidence to help empower clinicians. Okay, next slide. So this is just the slide we show when we say, look at all the evidence that we were looking at. So in order to create this calculator, ultimately, we did complete 35 different systematic reviews looking at all those different interventions. So most of them are pharmacotherapy, fair enough, but that's unfortunately also where a lot of the evidence is. So that's what we did. That's kind of the background piece. Okay, next slide is just this idea of how many patients get better. So that picture on the top right corner, I just love that picture because that shows all the different patient responses in a trial, right? So some patients, they start at 100 and it just goes straight across to 100 and nothing, they don't get any better. And other patients, you know, by the end of 14 weeks, and this was based on a real trial, their pain, you know, went from 40 to 0 on a visual analog scale. So when you report an average change, it's not really reporting a representation of the patient in front of you because you have no idea about that patient. So one of the ways to look at this data is to at least have a cutoff and say how many patients just got better, right? So if we said getting better is a 30% improvement, and most trials should be able to report this. They don't always, but they should be able to because they would have that data. So we prioritized randomized controlled trials that looked at how many patients got better with a specific intervention. Okay, next slide. All right, so this is the address for the pain calculator. And originally I was just gonna kind of go on there and walk through it, but just because of technical ease, we'll just do it this way for now. So on the right hand is sort of a quick overview, but I'll just kind of show a few of the highlights for you. So if you go to the next page, Carrie, thank you. So at the top, we always sort of have our happy faces that show you how many patients get better with everything. If you scroll to the bottom, you'll see that with each topic, low back pain, osteoarthritis, and neuropathic pain, we have a couple extra little boxes. So a little bit about the calculator. So why aren't we covering all the treatment options? Like I said, we're really trying to be, and we're trying to hold ourselves to a reasonably high standard, just reporting what we found in systematic reviews and randomized controlled data. So not everything has that. And we have links to the individual systematic reviews. So if you were sort of curious about a bit more information or whatever, you could always just link to the systematic review. And each of those had its own decision aid that we published at that time, which was a one-pager. So some people might find that interesting because the calculator itself is actually quite simple and straightforward. But if you wanted to dig a bit deeper, that's where the information is. All right, next slide. So here's sort of the home page. If you went on the CTOP tool, there's a drop down and you can pick neuropathic pain or osteoarthritic pain or low back pain. And then you can pick out of the options that we have evidence for. So here's anticonvulsants, for instance. And it sort of has the happy faces. So in the trials, the red ones show how many patients did not get better. So for this, for instance, about 56% of patients did not get better. As you all know, placebo has a reasonably good improvement in a number of trials, so almost 30% improved with placebo. And then the green is the additional benefit you would get with that intervention. And so we show it in a few different ways. On the right-hand side is the pain scale, so your VAS scale. If you started off with pain of 6, you know, maybe we can, and I like this, and I think I highlighted it a bit later, to set the expectation for the patient. What we're saying is about a 30% reduction in pain. That's what the trials majority will show, right? So it's not 100% improvement, but we can help move that pain down the scale. So that just gives it, and so it's called the calculator, like there's no numbers flying anywhere, but you can move it along the scale and you can demonstrate to your patient, you know, just to get a sense of that. Okay, next slide. All right, so underneath that is the adverse events. So what are the potential harms with those interventions? And so try to highlight them. So the adverse events are not always as well described as we would like. And that's because trials are terrible at reporting adverse events. They're really good at telling you how good their drug is, but not very good at telling you what the potential harms are. So, you know, we had many discussions about this. How do we do this? How do we present this? How do we get this data? So that piece that we've tried to do as well as we could, but there's definitely limitations in how it's reported. All right, next slide. Okay, so here is just an example, yeah, for osteoarthritis pain again. And if you don't pick, you can start with all treatments. And I think just hit one more, Carrie. Yeah, so, okay, so we also had a discussion in our team, like what's better, happy faces or bar graphs? And some people really love the bar graphs, some people love the happy faces. So we compromise. And so if you move one more time, you can toggle between this and you can get bars. If you like bars, fine, there's bars, right? So it just shows you, this is kind of nice because it shows you a nice comparison of all the interventions. And it's just showing the evidence compared to placebo. So you can see here we have a line, and what we did is we normalized the placebo rate to 40% to get these values. So the one thing that isn't here is the psychological interventions. And part of the reason that's not is because that wasn't part of the systematic review we did. That was a separate piece. And I'm always, you know, if you have feedback or comments, the other thing I will just say is we have, we're actually looking at the development of other calculators. And so we certainly, it's not that hard for us to go in and change things here. So if there's something you said, yeah, I'd love to see this, or this might be an idea, we'd love the feedback to make it as useful as possible. All right, okay, next slide, Carrie. There we go. Okay, perfect. So this is just showing you, if you wanted to look at all treatments all together, we sort of ranged them from most effective to least effective, just to give patients a sense. Again, it's just an education thing, you know, to help make an informed decision. Okay. All right, I have one more slide, I think. There you go. So this is just blowing it up again. Looking at oral NSAIDs as an example, setting the expectations of 30% reduction that you can run through with your patients. So yeah, it's kind of a fun tool. We were looking at stats. Looks like right now we had about 800 to 1,000 people accessing it a month, which is kind of neat. And just another tool out there to help. And like I said, you know, with complex chronic pain, obviously that's a bit different story. And we talk a bit about that in the guideline. The evidence around that is really tricky. So that's where the expertise you know, people who manage it all the time comes in. But this is really sort of a good start. And I think great for educating, you know, new docs, residents as they come in. Here's the best evidence we have, and kind of go from there. Okay, I think I was pretty close. I might have gone a minute over.
Thank you, Tina. I'm finally back and able to talk again. So thank you very much for your presentation. And now I'll open it up for questions from the audience. We have about 5 minutes before we start our case presentation.
So Tina, I'm going to start off. Have you had any patient comments on the patient tools? I certainly have used it with patients and they found it super helpful, but sometimes depressing when they see the, you know, all the different medications we've tried them on, and yeah, and the effectiveness. But I was just curious if you've had patient feedback.
Yeah, so great. So good question. So yeah, some of them do get a bit frustrated when you show them this calculator, because you're right, it is. It's and it's different than like when we use the lipid calculator, because they're like, yay, it doesn't work, I don't want to take that med anyways. But when it comes to chronic pain, it's like, well, no, I really want something to help me here. I really want something. So you're right, it is. It's an interesting dynamic. And actually, sometimes when I use it more with my residents, with my teaching, and then discussion with patients on occasion. But it's more, personally, I find it more useful as like a physician education tool. Like, what is the evidence for these different things, and then being able to describe that to the patients in a more positive approach.
Great. And then I guess my second question is, are you doing a review of the psychological treatments for complex chronic pain? And I know it's fraught with
yeah, so we, like in the chronic pain guideline, that was a sort of a supplemental question. And, you know, even as I go through it now, I was sort of debating with myself, because we did find some RCTs that show evidence of benefit. but it's not the same like it's not a systematic review. It's not the same standard of evidence. And we have this discussion within our team all the time, because there's what's useful and then what will be held up to the, you know, the holy grail of reliable, high quality evidence. So yeah, even as I sit here, it'd be interesting if you could add it with a little asterisk or something like that. Yeah, it's a great comment.
I was actually thinking from the perspective of using it with patients, it might actually really bolster the idea of placebo effect and the power that so oftentimes, at least in like my chronic pain population, you know, I'm talking about like placebo effect comes from somewhere. Our brains can do this. We just need to figure out how to harness that for you. And so I kind of wonder if there might be some power in saying like medications are good, but you know, look at how many people get better with control. Yeah. Look, you know, like look at the strength of what we can do when we set our minds to it. So anyways, I think that is I think it's a really cool tool. I'm going to have a look at it and delve a bit more deeply. Thanks for the presentation.
Yeah, you're welcome.
I love the exercise because that's cool. You know, the bar graph exercise and convincing people. So it's been super helpful on that. So thanks, Tina.
Well, I would just, Lori heard me going on about this yesterday, but it's just like my favorite part. I love, because before I wasn't really sure, and patients would come, and I think maybe we see a bit of a spectrum bias ourselves in primary care. People who are exercising and doing okay don't come see us, but the ones who are exercising and they still have pain, they come see us, and we get this message: exercise isn't helping. Exercise isn't helping. And so to have, and when you look at the systematic review, like I just love that metagraph where it just shows, you know, I don't know, 20 plus RCTs. Exercise better every time. It's like, it's really, then I can really share that with my patients. Like, I think this can help you, you know, if we can do it the right way.
I just noticed a good comment in the chat. The inclusion of the determinants of health would be difficult, but it's super useful, especially when we start looking at non-pharm, because it's not covered. And so then our most vulnerable patients end up on medications because they're covered, when some of the best treatment might not be those medications. Comments, Susan.
Yeah.
I think we'll keep going. Thank you very much, Tina.
Okay, thank you.
Thank you.